fancy with my clicks too, so I'll direct you.
Are you gonna snap at me?
I don't know. What do you like? I'll figure it out. All right. So I have a lot to talk about today, and I think I'm double microphoning. There we go. Okay. So I have a lot to talk about because boy howdy has there been a lot going on in our world, and it is a constant vigilance of watching for changing policy and things that might impact your cash flow. So that's what I'm here to talk about today. I'm going to start essentially with the big picture from the federal level and sort of how that impacts the state policy and some of the overarching themes with interoperability. And then I'm going to talk about, okay, what can you do to manage this data yourselves? What do you have the ability to do within your organizations to make sure that you understand who is within your population, what type of Medicaid coverage they have, because it's important. As things change, we hear a lot of words. Thank you. We hear a lot of words, right? We've heard a lot of words over budget season, and I made this. There's free word cloud software that you can use, and it's fun. But these were like the top words that showed up within House Bill 96 in Ohio, and within House Bill 1, the big, beautiful something bill. But we've heard Medicaid expansion, Group 8, prior authorization, re-entry. Am I double microphoning again? Okay, let me turn him off. Mute. Okay, I think I'm good. Yeah. Okay, so let's dive into this big, beautiful bill right here. So this graphic was put out a couple weeks ago by the National Association of Medicaid Directors, and it laid out the timeline for some of the provisions within the big, beautiful bill that are related to Medicaid and Medicaid eligibility. So on this first one, and I know that this is itty bitty, I tried to do like a Zoom thing and that doesn't work. But these are all distributed as well, and pretty much everything is clickable. It will link to the actual source so that you can, follow up and do more research on your own. But basically on this first one, it's talking about the restriction on funding to certain family planning providers. So that affects our Planned Parenthood, provider tax provisions this is the part that I don't understand. So really all of this page doesn't impact us all that much, but the next one does. So work and community engagement requirements, right? That's the big one that's been discussed around Group 8. The timeline for this. So states must require certain expansion adults to complete 80 hours per month of work, education, or community service as a condition of eligibility. This applies to individuals that are 19 to 64 with limited exemptions, and it has to be verified through this ex parte process, which is just like a third party. So obviously that's very impactful to us. The work requirements, you saw all through budget season, right? Everybody's really advocating that this is going to be a difficult thing to meet. 80 hours, that's a lot. So we're going to have some difficulty there, and especially with the 6-month redeterminations for that same subset of people. So 6-month redeterminations. Right now it's 1 year, so every year, you get a letter and they go through the process to say, hey, it's time to redetermine whether you're still eligible for Medicaid. And at that time, they will make a determination and go on about your business. Well, now that's every 6 months for this Group 8 population. And that will begin January 1st, 2027. But it has to go through a process, right? So this is coming down from the feds And then he needs to go CMS to sort of figure out the how, what, where, all that good stuff. So there's still things that have to come out, but we're watching this very closely. And each one of these is aligned with the section within the bill. So the section numbers are on there, and that's helpful. Although this one's wrong, I need to tell the National Association of Medicaid Directors. It's 71107. So retroactive coverage limits. So we were talking about that changing Medicaid. You know, you look at it at one point, and then you go back, and then it changed, and it's like backdated for 3 months. Well, they are going to reduce retroactive coverage from up to 3 months to 1 month for expansion adults and 2 months for all other groups, also effective January 1st, 2027. There's a waiver option, totally don't know what that is, other than it has to remain budget neutral. Also, I don't know. So if Medicaid wants to do any special waivers that they're gonna put out, they have to make sure that it, I don't know, cost sets. And then cost sharing for expansion adults. This really doesn't apply to many of the people in this room. So the cost sharing will not apply necessarily, but it would be a $35 per service copay and 5% of income. So this is, you know, from the national level, this is what's coming down from the feds. So, thank you. This one, again, links on links on links. I like sources. I like you to be able to go out, do your research, because I don't have a lot of text on this slide, because that would make everybody's eyes bleed. And again, I'm really just outlining, like, what are some of the things that we're watching, because they may have some impact. So I already talked about the work requirements, 6-month eligibility redeterminations, ensuring deceased providers and members do not remain enrolled. So everybody remember when they turned on that edit in the P&M, and if you had a deceased board member, just terminated your whole group ID. So yes, they have to build in those automations, and that's coming from the federal level to say we cannot have providers and members that are not alive to still be in the system and, you know, eligible for things. They're inflating numbers. So CMS, interoperability and prior authorization rules. So I'm going to get deeper into this one because I'm so excited. I'm so excited because I'm a tech nerd and I love it. And this is all about data, exactly as Darren was saying, right? And exactly as Bridget was saying, there's data. And now we have this ability to consume and understand data in a way that we never have before. So this is, you know, putting analysis in everyone's hands. And interoperability and prior authorization, basically what we're trying to do, the very first thing that's going to impact us is the timeliness of the prior authorization requests being a standard 7 days. But again, I'm going to talk about that in a second. And the CMS health information, or no, health technology ecosystem, that's pretty exciting. So I'll talk about that in a second. And then from the state perspective. So this is more so why we care and why this impacts us. So in the state budget cycle, they did add revised code 516304. And that is the infamous kill switch. So the kill switch is basically stating that if the federal money that is being provided to Group 8 members, if that drops at all, a little bit, just a little bit, at all, that they would have to immediately terminate coverage for those members. At this point, that's not. They implemented, they're adding an audit and correction plan for ABD enrollees. So that's your age, blind, and disabled, and I'm going to go into that as well. But they are expecting, Medicaid needs to do an audit on their own data and look for inconsistencies, duplicate enrollment in programs. Speaking of audits, next gen audit. So they have to audit this next generation project and the implementation and work that's gone into it. And I believe it's by the end of 2027, but I'd have to click the link and find out for sure. I don't have that one written down. So that will be, I think, important just to keep an eye on. I don't know any specifics, but I know I'm going to be watching it very closely because it has been incredibly impactful and administratively difficult. And I think everybody in this room has really felt that over the last couple of years. So I'm grateful that our legislature is seeing that and that they're making sure that it's being properly audited and documented. The social gender transition. Now this one, I was having a difficult time finding additional resources on. It's not officially yet, and I don't even know, it says section 331, that's not a section. I don't know where that is. So either way, it's one that we're gonna be watching, but it's basically saying you can't provide Medicaid funds to support that transition. I kind of want to pull up the actual language. You know what, I can, because it's my computer and I do what I want. Hold on. Okay. Beep, beep. There it is. Okay. Can you control? Oh, yeah, there you go. Oh, no, I linked it to the MRSS journey. Okay, I'll find it later. Don't worry about it. Nope, nope, nope. Beep, beep, beep. Okay. So, and then we've got MRSS statewide expansion, which we already discussed, and then CCBHC. Get ready to start hearing those letters and that very long acronym that is very similar to other acronyms in the same field. But that whole person care, they're saying that they need to come up with a certification for that and a process to certify providers to become CCBHCs, so like truly certified clinics. Okay, next slide. And we'll see how well this works. I have a lady that's going to talk to us. Oh no, it's so quiet. Hold on. Now if I can F3 this. No. See if it's yeah. Okay. Subtitles are on. Read.
12 doctors take 21 medications. And then managing her healthcare like 1995. Until recently, when she uploaded her health record into an AI system just to see what would happen. What it found was a critical discrepancy in her diagnosis that could make her eligible for a clinical trial. The first real hope we've had in over 15 years. It's become possible when we stop accepting what's broken and start building what works. Imagine scanning a QR code at your doctor's office and instantly sharing your medical history, just like when you board a flight. Imagine having an AI system that knows your care plan and helps you manage medication with confidence. Picture patients truly at the center of their care, building
Department of Health and Human Services.
Yeah. So that was put out by CMS on this health technology ecosystem. And really the overarching theme, right, is interoperability. And you're going to hear this word, and you're going to hear it a lot, because it's being able to work cohesively and instantly with each other, with your patients, with insurance. So, submitting a prior authorization electronically and getting a decision, a thorough decision, an actual decision electronically. Being able to affiliate yourself with a member so that you can then access data about other services that they're receiving. You get to really understand, and that's where everything is so segmented, right? I go to my therapist, and or my psychiatrist, and I'm prescribed something over here, and then I go to my endocrinologist over here, and there's all of these separate systems, but really it's whole person care and understanding what that person's journey has been, and then this is providing the access to do so. And really taking all of this to the next level. And so I'm a Qualifax, CareLogic, all the way. But recently I went through the Cleveland Clinic and the Epic systems. Oh, it's so smooth. It's so smooth. And my statement, horrifying but beautiful. Okay, so but it was all instantaneous. I've got my test results, I've got my doctor's notes, I've got everything right there, and it's made available to me before it's even made available, before my doctors have viewed it. And it'll tell me that. It gives me that little indicator at the top, and it'll say, your care team has not yet reviewed this. And I'm like, okay, I'm gonna wait for that to change so that I can get an outreach from my doctor. It's like, I know you read it. It's like a red receipt, on your text messages. I'm like, no. I know you saw that at 10 a.m. Don't be responding to me at 1, okay? So that's the goal, is interoperability, being able to work together, being able to provide patients with their data all the time. And I just love that. So this is the framework about patient access and empowerment. So again, I am so pro this, but there's of course concerns with what is going to be made available to them, especially in our space, right? Clinical notes from your therapist are a little bit different than your endocrinologist. A lot more sensitive data. Is it really something that should be immediately shared? And then of course from your own documentation considerations, when you're documenting, if you know the client's going to be viewing the data, you might be documenting a little bit differently. So just something to be aware of, because they're also talking about all past history as well. And the whole ecosystem they're developing is about the human readable. So I don't know if anybody else is a total nerd and has requested their health data, the computer readable export, because I can't help myself. So I've done that, but it's not human readable, and it's very, very clear about that. So it's about making it so that anybody who reads this can understand this person's care journey. Provider access and delegation, so full treatment access. If the provider is verified as an active provider in the CMS National Directory and attests that their request is for treatment purposes, being able to share that information with other providers. Data availability and standards compliance, so your chart notes and clinical documents, for example, radiology reports, scanned or faxed labs, external specialists, they are going to be returned in both machine and human readable formats. And a lot of that is to enable this application development. So that's what they're saying. Hey, I want OpenAI to commit that they're going to, make an app, and you'll have ChatGPT that can help you manage such and such with your health data. But that's what they're looking for. They're looking for that development with applications alongside providers and making sure that everybody's talking, because nobody's been talking. This has been my biggest gripe about next generation Medicaid, is that there was a crucial stakeholder that was left out of that implementation process, and that is the EHR layer. The EHR layer was left out. So now we're all dealing with that. But this is an opportunity to be involved in the process, provide comments as they develop. And I think it's really important because it will impact you. It will. They're saying that by July 4th, networks must provide or facilitate access to this data using these APIs. I know CareLogic has APIs in the back end. They've got a whole API structure. So this is all coming, and it's coming very quickly. And that's really where, just from the federal level, they're saying, hey, I'm here for it. I'm accelerating this. We want you to do this. We're not going to provide those barriers that we have in the past. We have to move quick. Network connectivity, so this national provider directory, and then the identity, security, and trust. So all queries must include the purpose for the request, and I like that. So yeah, pretty interesting. All right, prior authorization processes. So this is the first thing in the wave of this interoperability. And it's the time frames. So they have 7 calendar days and expedited prior authorizations within 72 hours. This does not include qualified health plans on the exchange. So there's that. But it does include Medicaid plans, Medicare, all the CMSers. Providing a specific reason for that denial, so they have to say exactly why they're denying, which I didn't realize they didn't have to do now, because that's wild. They can just like, I don't feel like it. Prior authorization metrics, so understanding across the board, the prior authorizations that are being submitted and what payers are approving, denying, and this will all be on a public website on an annual basis. So, neat. Okay, so coming next in this journey, beginning the 1st in 2027. There's a lot of stuff that goes on in the 1st of 2027, so buckle up. Next year we'll talk about it again. The API requirements, so they must implement and maintain a prior authorization API. So API is application programming interface. You don't need to know that, but what you do need to know when it comes to APIs is it's all about apps talking to each other, having the ability to submit data electronically to each other. So they're saying that this needs to be for prior authorizations, electronic, by January 1st, 2027. Identifying whether that item or service even requires a prior authorization. So that's nice, being able to query and just double check, just make sure. Payer-specific documentation requirements. So the API must identify the payer's documentation for all items and services that require a prior authorization. So, you submit for partial hospitalization and, very specifically, they're going to ask you for that diagnostic assessment, treatment plan, level of care determinations. So having that electronically available to the standard user. And then exchanging those PA requests and responses. So being able to communicate again. Okay, these are the ones I'm super excited about. Provider Access API, also the first in 2027. So they must implement and maintain Provider Access API to share patient data with in-network providers with whom the patient has a treatment relationship. So how does somebody establish a treatment relationship? Well, they have to figure that out. And that's that third point about attribution. So, and there's data, right? Like I know that they're currently collecting data and they can say like, hey, this appears to be your list of providers based on claims submitted by you for them. So, coming up with a standard way to make sure that that attribution is accurate and doesn't disclose inappropriately where it shouldn't be going. And then opt out. So patients can opt out of having their health information available and shared. So if a patient does not want it, they can say no. Yep. Okay. Payer-to-payer API. This one is making available claims and encounter data, excluding the remittances and enrollee cost sharing information, but sharing that claims data and prior authorization data, payer to payer. And the important piece there is this one here at the very bottom, concurrent coverage data exchange. Yeah? Finding out right away that somebody has other coverage. So where a patient has concurrent coverage with 2 or more payers, impacted payers are required to exchange patient data with 1 week of the start of coverage and at least quarterly thereafter. So again, encouraging that communication payer to payer to validate this information and not relying on the TPL in the P&M that's been active since 1980 and apparently has never changed. Next. Okay, so we talked about sort of the why, and now I want to go back to the beginning, because I will admit I was painfully uneducated when it came to the actual eligibility pieces and what it means to be in these various categories. I hear all the words, I hear expansion, I hear ABD, I hear CFC. It's too many acronyms, but I personally wanted to understand, okay, what does it all mean so that I can do something about it? So that's what I'm gonna talk about now. Okay, so Medicaid and Medicare, and I grabbed this, HPIO, Health Policy Institute of Ohio. I have no affiliation with them, but my goodness, do they have good data, such good data. And this was from their intro to Medicaid 101 deck that they have out there, but really good information. So Medicaid, right, it's low incomes and other factors, which we'll get into. But it's providing your primary, acute, long-term services and supports. It's federal and state funded. Enrollees generally do not pay for any premiums or expenses, although we know that that's going to change a little bit with the premiums and the cost sharing for the copay for Group 8. So it also provides benefits that Medicare does not, right? Like your case management services. I mean, MRSS, right? All the things that we talked about, it provides additional services that Medicare does not. And then of course your Medicare it pays for care for nearly all older adults. So sweeping, generally 65 years or older. It's based on age or disability status and work history. And again, it can provide primary and acute care only. So this is where those specialized services that perhaps Medicaid pays for them, Medicare doesn't. And that's where you get your TPL bypass list that applies to us. And it is federally funded through payroll deductions for most employees, employers, and self-employed people. And these enrollees do pay part of that cost. And you'll see that sometimes where you have a dual enrolled member where their Medicare says, hey, here's their 20% coinsurance, and then you take that coinsurance and you give it to their Medicaid side, and Medicaid pays for that coinsurance portion. So, the 3 key eligibility groups. There are other eligibility groups and statuses, but through our 270, 271 process and just all of the other data that's out there, it really comes back to these 3, right? So CFC is covered families and children. So it's children up to 18 with other insurance and without, although there's a difference in the total income, the federal poverty line standards, which I'll talk about. Parents, caretaker relatives with 1 or more children under 18, and pregnant women. Pretty straightforward. Expansion group. So this is adults 19 to 64 with low income. And I'll talk about that federal poverty level, that FPL that we're always talking about. And then you've got your ABD, aged, blind, or disabled. These are adults that are 65 and older, or those who are blind or disabled as per the Social Security Administration. This piece right here, Magi, anybody want to help me with that one? Magi, thank you. I question myself every single time, so here in front of you all, we have agreed it's Magi. Okay, Magi, and it's just a tax calculation, right? It's tax calculation. You deal with it at the end of the year when you do your taxes, or TurboTax does, because that's how I do it. So I don't know what it's doing, but it's doing math. And this applies to this group that gets this 5% disregard. I'll talk about that. Then you got your ABD that falls into this other category. This is not MAGI-based. This is based on disability or age. Next, please. Okay, so the key terms, right? So FMAP. I wanted to start there. So FMAP, this is that FMAP trigger language. So the FMAP is your federal medical assistance percentage. United Healthcare, I do not have time to talk right now. Goodness. So for most services, and I found this fascinating. The sound is doing things. Okay. I won't go near it. So I found this really interesting. For most services, so Medicaid is joint federal and state funding. And normally, and they pay more, usually, so 65-35, approximately, is that split. So the state, for regular services, non-group 8 population, the state is contributing about 35% to that budget for the year. So like when we were going through this legislative process and we're really concerned about what are we going to do with Group 8 and what's coming, the big concern here is that the federal money for Group 8, they pay 90%. So basically the state only has this teeny tiny sliver that they actually have to pay for Group 8. And they don't want that teeny tiny sliver to get any bigger. So this is where they put that trigger language to make sure that, hey, if something changes federally to this group of enrollees, that the state is not going to end up with this enormous bill on their hands that they did not budget for. So that's kind of the intensity there. Listen, I'm not going to talk about this, but there's math involved for MAGI, and it's just a calculation. So it's like, hey, you take some things and you can deduct them, and then you add them back. So we're kind of, there's the federal poverty line. Okay, so this is what federally they've said is the absolute, that's the bottom line, right? Where somebody can survive and meet their basic needs on this. But for these government programs like Medicaid, we kind of inflate that a little. We're going to give you a little bit of wiggle room and maybe deduct some things just based on your status and different qualifications. So as you're going through that eligibility determination process, they're going to ask you for your firstborn child. You have to deposit them. No, but you do. They're going to ask you for like a ton of data, and it's going to be more stringent, and all of these systems are now going to talk to each other better, we hope. But that's essentially, they can add some stuff back in to make you a larger group of people eligible for these services that are so needed. So that's this disregard. So basically we're like, okay, well this is 100% of the federal poverty line, that line, but like we're going to give you a little bit more because for eligibility determination reasons, we're giving you a wiggle room. Then SSI, SSDI. So I don't know about these things. I'm not there yet. I'm not talking about it yet. So I wanted to talk about it and make sure that we all know sort of what it is. So you've got supplemental security income and Social Security disability insurance. And sort of the split there, okay, so one is needs-based and one is not needs-based. So SSDI is not necessarily based on the finances. So you qualify for SSDI based on disability criteria and work credits, so your work history. Then you must have paid into Social Security, and then you're eligible for Medicare after 24 months. So once you get that determination, it's 24 months. So then for SSI, you qualify based on disability, age, blindness. It is needs-based, so there's financial need that has to be proven there. You do not have to have work history, and it makes you eligible for Medicaid. Next slide, please. Okay, so this slide here just talks a little bit more about this, and I'm going to focus in primarily on this right here. So there's a program that is called SRS, and it is a mystery program, I think, for most people that don't understand it. So ultimately, and I've been working with some very educated individuals on this topic, but basically, if they're awarded, right, so they're determined disabled, and if they're in that expansion category, they can remain expansion eligible. So like this can happen concurrently. Now, if they get SSI, so this is, you know, as soon as they're awarded that, they're going to convert to ABD Medicaid, age blind disabled. But the SSDI, you can remain expansion eligible for 24 months. So they get awarded the SSDI, they make 24 months payments, and then they become Medicare eligible. When they become Medicare eligible, they are no longer eligible for expansion. So this SRS category that I'm going to talk a little bit more about here in a minute might be an answer for expansion Medicaid and some of these people who are potentially losing coverage. There's a list, qualifying diagnoses, things that you can do as far as establishing whether somebody meets the criteria for this program, that, you know, you get this like recovery services, you get like extra services, but ultimately it makes you eligible for Medicaid, full service Medicaid. So that's the important piece there. Next, please. Okay, so I'm going to talk a little bit more about those three main categories and dive a little bit deeper. So CFC, covered families and children. Again, this includes children with ages 18 and younger and households. So it's up to 211% FPL, so federal poverty level, if there's no insurance involved. And then up to 161 with non-Medicaid health coverage. So again, all of these numbers bug me, but you know, we've got sheets, we've got numbers here. So in the appendix of this of these slides, I have the latest numbers, the full Medicaid chart for these different aid categories and the monthly income along with that disregard. So it is in the appendix, and you all should have that in your email. But if anybody needs it after, of course, we can send it. So, you know, as far as the numbers go, this is just a sort of display, right? Monthly income for the family size. So for Magi, right, it's based on family size and income to calculate sort of what you qualify for. And those are some of those categories. And this does include that 5% disregard that jacks up the total. Oh, and pregnant women, and I missed the parents and caretakers. I'm a parent, why did I miss that one? So this is income's up to 95%, and of course just child younger than 18, and then pregnant women up to 205% of the federal poverty line. Next, please. ABD. So this is 65 and older, or legally blind, or are disabled as classified by the Social Security Administration and must meet basic requirements. So the interesting thing here, most people in this category are younger than 65. So like this is the age blind and disabled category, but I'll show you the numbers. So this is where I got fancy. I'm gonna click. Okay. So this is from the Medicaid aid category table, and I'm going to talk about this in a bit. And this is your numbers. So everybody's got to know about this. So we are doing an initiative, an eligibility management initiative, alongside Mr. Rip Tully. It's over there. And basically, this SRS is it's meant to assist with individuals in this category. So it seems a little scary and administratively prohibitive, but it's not that hard. There's a list of diagnoses that are out on the website. It's a very long list, and you could have somebody with qualifying data. And if they're in this expansion group, and you know that they're, maybe they are now working, or, data is going to get pulled in, people are going to lose coverage, there might be an answer through the SRS program. So we're going to do more education on that in the future, but I want to bring it up because there's this timeline that's associated with it and the Medicare enrollment. Essentially, you have like 24 months. So you get awarded disability, and then the clock starts, where you have to figure out how to maintain Medicaid enrollment when Medicare kicks in. And SRS will maintain that enrollment. So that's really the important piece on this slide. It's people who are diagnosed with a serious and persistent mental illness, a chronic condition, or who are active on the transplant waiting list. But it's a really long list of diagnoses that qualify. So it's important. Okay, Medicare premium assistance. From a billing perspective, I wanted to put this one on here, but because QMB. Who has fun with your QMB enrollees? Huh? Yeah, right, I got murmurs all around the room. So QMB is your qualified Medicare beneficiary. And I bring this up here because these guys, not eligible for regular Medicaid services, okay? So if you see SLMB, they are not going to pay you for the Medicaid services. If you see QI 1 or 2, they are not going to pay you for their services. So that's important. They pay for premiums. They pay for premiums. Now, QMB, a little hairy, and I'm going to talk about it. So QMB will pay the Part A and Part B premiums, deductibles, copay, and coinsurance for Medicare-covered providers and services. So what does that mean? You have to bill Medicare first, right? So you go in and let's say this is an assessment and you're billing a 90791 and this patient is in original Medicare. Well, original Medicare has their internal bypass, so they're going to do their adjudication, and then they automatically are going to transfer it to whoever they have on file that is next. So if your patient has QMB Medicaid, it's fee-for-service. So they're transferring the claim to fee-for-service Medicaid, and then Medicaid is to pick up the deductible, copay, coinsurance. There's been a bug in that, though. So the crossover, when there were issues with file transfers, those were not crossing. So Medicaid wasn't receiving the Medicare files. So some of those QMB, I know that there's been a lot of confusion around it where it's like, well, they're not going to pay for anything, so let's just write all these services off. No, they are supposed to pay the cost share from Medicare. So there's a whole process where you use the 6614 form and you can upload it to the claim and the P&M to provide that original insurance adjudication. Hopefully you don't have to do that. I've been pretty successful, but it's complicated. So if anybody has difficulty with that, highly recommend reach out to us because there's tips and tricks. But anyway, not standard services. So that's important to understand this category. Next, please. Okay, expansion. That's the fun one. So this is the category that everybody is soups concerned about, understandably, and it's adults up to 138% of the federal poverty line. So this is your line. They're not eligible for Medicaid under a different category, so they're not ABD, they're not CFC. This is just the others. And Sarah, if you could go to the next slide. This one I have from the Office of Health Transformation, which is previous. So this was Greg Moody, and this was from a deck that was presented to JMOC during budget season. And I found this graphic incredibly helpful. So this just really visualizes, right? Children 0 to 18. Here's your 100%. I don't know if they want me touching that, but I'm going to do it anyway. So there's your 100% across the line. That's 100% of the federal poverty level. So right now, this is how things are structured, okay? So then you've got parents, which they're already in, right? You've got CFC, and then you've got adults, 19 to 64. So today, it's up to this 138, and then after that, you go into the marketplace. I also want to point out that there is some overlap here, right? So parents, Marketplace, so somewhere between 138 to 200, a parent can qualify for Marketplace and a child is still in Medicaid. That might be where some of that confusion is coming in. So this slide then talks about this, what used to be a coverage gap, and it's the gap that we're concerned about now. So it was these individuals that were just not included in previous categories. So you have to be a US citizen, 19 to 64. This did say 21,600 was 130% of the poverty level in 2025. So this was updated for that budget season. Age 55 or older, parent caretakers, enrolled in school, yada, yada. You can read that. But so it's this coverage gap that is currently good to go. We're covering them now, but they're at risk. And understanding who they are is important so that you can perhaps help, right? Okay, what's my time? I don't know.
We're at 11:14.
14, okay.
Yeah, 11:14.
Oh, score. Okay, I got all kinds of time. All right, so this is the proposed work requirements. Again, another service or another group that's incredibly helpful is this KFF. And just really, really good data out there on this stuff, so highly recommend that group as well. And if you click on the image, it will take you to the website. So the qualifying activities for this group, and again, it's the expansion folks, so 80 hours per month of work, community service, and or work program participation. So this is where that policy development comes in. They have to figure out on each level, both CMS has to put out guidance, and then the states have to take CMS's guidance and then figure out what they're gonna do with it internally in their policies. So Ohio submitted a work requirement waiver that was less stringent than the federal government. So that waiver that's kind of sitting out there, it's gonna get rejected or canceled or something, and then they're gonna maybe submit for a new one, or just it's gonna be part of policy. Yeah, they're gonna wait. Yeah, so they're gonna wait for the guidance from CMS. But up until now, right, you've had individual states who have been able to submit to do these work requirement waivers. So certain states already have this in place. There's been a lot of talk about Georgia. Apparently it's a dumpster fire. So we're lucky, I don't know. So that's important. So yeah, they have to be enrolled in education at least half of the time. If the work isn't there, any combination of the above totaling 80 hours per month. So 80 hours per month, call it 10 hours per week. No, 20 hours per week. And then seasonal workers with an average monthly income over 6 months of minimum wage multiplied by 80 hours. Don't make me do that math. I'm not gonna. So those are the qualifying activities. Mandatory exemptions, so if it's parents, guardians, caretakers of dependent children under age 13 or disabled individuals. So that means that if you have a child 14 to 18 still in your home, work requirements may apply in this case if you're in that group 8 and you're not covered under one of these other exemptions. Pregnant or receiving postpartum coverage, so if you're pregnant, you don't have to do it while you're pregnant, and then a little bit after. Foster youth, so under the age of 26, medically frail, again, we're gonna need some definitions and some actual information there. Participating in SUD program. What is that? Is that outpatient? Is it a requirement of, partial hospitalization level of care? All has to be determined. Meeting SNAP or TANF work requirements. American Indians and Alaska Natives are not on the list. Disabled veterans, incarcerated or released from incarceration within 90 days, and entitled to Medicare Part A or enrolled in Medicare Part B. So essentially ABD, you're covered. You don't have to worry about it. These are the people that are not covered in one of these other categories, right? They're not age-blind disabled, and they are not child or parent. And then there's the option for hardship exemptions. So it's a state option. So the state has to say yay or nay whether they're going to allow for these additional exceptions. For short-term hardship, so somebody that was inpatient, hospital, nursing facility, yada yada, resided in a county with a federally declared emergency or disaster. So if, Avon Lake, we had a tornado come through, and I mean, it wasn't called a disaster, but if it was, then the state can choose to let those people go for the minute. Reside in a county with high unemployment rate that is above 8% or 1.5 of the national unemployment rate. So we'll see. Traveled outside of the individual's community for an extended period for medical care for themselves or for their dependents. So I'm even thinking PRTF there, where perhaps somebody's had to go receive treatment elsewhere for lack of coverage or whatever. So this is what's proposed. This is what's coming. So now I want to talk about, well, how do we find out what kind of coverage our members have?
Hey, Chelsea.
Yeah.
So just one thing, since it's not explicitly stated in that mandatory exemption, so mental health is included
Mental
under the medically frail. It's like you have to have a disabling mental condition.
Okay.
So I didn't want people to think it's just SUD that's excluded.
Okay, so
But again, we're going to need a definition.
right, a definition, probably qualifying diagnoses, exactly what lists for that. So mental health, that's what Soli was saying, mental health is included in that SUD. It's just a matter of defining what exactly is part of that exemption. Okay, so I'm going to talk about eligibility verification methods, and I'm going to clarify, I am talking about verifying Medicaid eligibility. So like, go to fee-for-service, you go to the P&M, I hear it. So this is just to verify like through the P&M or through the 270, 271 process, but straight to fee-for-service Medicaid. Because again, they're the source of truth, supposed to be. They're the source of truth. So I want Medicaid's data telling me if they're eligible or not, if they have a managed care, other restrictions, limitations, and this aid category that we're all very interested in. So let's talk about our available methods. And this is not an all-inclusive list, but I thought it was important. So part of it, you've got your IVR, so that's when you call the provider services line. I don't know if anybody knew you can do that. You can call provider services line. You can check somebody's eligibility on the phone. You don't have to talk to an actual person. You just punch in numbers and it will give it to you, but it takes a while and it's not very helpful. So the search criteria is one of the things that really differentiates these different methods. So like with the IVR, you can search by only the member's MMIS, so their Medicaid ID. Usually it requires at least 2 data points in all other methods except for the IVR. Now, you can only do that once you've validated that you are in fact a Medicaid provider. So you have to like sign in, if you will, on the phone with your number, and then you can just punch in the MMIS and it'll give you that information. So I thought that was cool. First name, last name, date of birth, and then these are all just combinations of that, right? So basically in the P&M, you can see it's date of birth and social, date of birth, and the member's Medicaid number. IVR, MMIS, and date of birth and social. And those are your only options. For the 270, 271, well, that's a horse of a different color. You can use all kinds of combinations. So we're going to talk more about the 270, 271, and I hope I'm not going to bore everybody to death. I'm going to make it fun. The transaction returns. So I want to talk about the sort of benefits and some of the additional data that you can get from the 270, 271 process that you may not be able to get from the others. But as I was doing this, I discovered that you can get the case number. You can get their case number when you call the IVR. So I thought that was neat because sometimes, especially for the dual members, right, that have like, I don't know, 2 Medicaid numbers out there that are overlapping.
I'm curious
You can get it on the CareSource portal? Okay, yeah, so for them, if they have managed care, right, then you can go on the provider portals as well. So like there, you can find it on the CareSource portal. But from Medicaid, as far as I've found, it's the only one that gives you that is the IVR. There's this aid category code, so this is that number that we're going to talk about that essentially defines what kind of Medicaid this person has. The subscriber's current address, that's on file. So I don't have to send an address at all, but if it's in there, it's going to give me what they have on file when I do the 270, 271 process. And that's helpful when you think about 6-month redeterminations. You know, how do I reach these kids? Well, it's you reach them by their address, and if their address is incorrect, you won't be reaching anyone. I've been receiving somebody's mail at my house that hasn't lived there for 20 years, okay? I finally said return to sender. But, so that's a real concern, is people being dropped for administrative reasons. They didn't get the letter because they haven't lived there for 20 years. The subscriber county, so the P&M does give you their county, Trumbull, up at the top there. The IVR does give you their county. And then you got your Medicaid managed care, Medicare, TPL, the P&M and 271 give all of that. The IVR will tell you their managed care plan, but it just reads it, and I'll show that in a second. The patient liability, long-term care level of care, and any other restrictions, so your 271 and P&M, and then error reason for incorrect data. I like that one because if I have incorrect data in my system, like maybe the date of birth was incorrect, well, no other search criteria necessarily tells me what data point is wrong, but the 271 will. And it does a lot. It's very stringent. You have to have perfect data points, but I do like that. So these are your 3 methods, verifying just fee for service. Who do they got? Next slide, please. Okay, so now I'm going to talk about each one. I'm going to be short on the IVR because, it's fun and it's not as fun. But so I did put a guide in here. I tried this, I called, and it took me 5 minutes, so it was rather lengthy for one member. But it was interesting. So basically, like you call, and I have the numbers here. So you press 1. You can skip through. So it's like as soon as it starts talking, if you know what option to choose, you can hit that option. So I guess you can speed it up a little. So you have to validate your Medicaid provider. They basically have to, check in and say, this is who I am and why I'm checking. Then it will ask for the earliest date of service. It'll give you 48 months of data. So like if you want to go back 48 months, you can do it this way. It'll confirm whether they're eligible or not for the date of service. And then it'll state whether they're eligible for managed care. And then it says you got to press a number to find out who. So then, you go through that little mystery session. You press 1. And then this is what it does. So this member has Molina Healthcare of Ohio, Inc. at 3000 Corporate Exchange Drive, Columbus, Ohio, 43221. So it doesn't really tell me what I need to know, other than I know where to mail a CMS 1500 form and then have it rejected because I don't accept them. So this isn't exactly that helpful, but might be good in a pinch, But you do have this option available. This does not give you aid category of any kind. So this does not say anything about what kind of coverage they have, just whether they are covered and by whom. Next, please. So then let's talk about our favorite, the P&M portal. It has been better, I will say that. So for the P&M, again, you can use the MMIS and date of birth or social security number and date of birth. But you have to have one of those 2 combinations to be able to use the P&M. Then I thought that this was really interesting. And again, I just steal slides from other things because they're helpful. And why create, something new when it's already there? So this is quite literally from the Medicaid training on P&M, on the eligibility. But I did some highlighting. So the benefit assignment plans, this is going to show, so for somebody to be fully eligible for Medicaid, MRDD, targeted case management, alcohol and drug addiction services, Ohio mental health, and Medicaid should all display in this panel. Also notice right here, it does mention MAGI, CFC, those are two terms that we know now. So it does mention that there as well. So I tested this with all of the codes that we've identified as Group 8, and I think it's all of them have MAGI, Alternative Benefit Plan Medicaid Expansion. So if you see that real long one, that is your expansion group. And that's how you're identifying them in the P&M. Next, please. Let's see here. So if they're also enrolled in a managed care plan, you've got your managed care plan details. This is also where under that managed care benefits, you'll see your opt-in and opt-out. So if somebody is full dual through the MyCare plan, it now says that in the P&M, and if they're Medicaid only, meaning that they've opted out of the Medicare portion of the MyCare plan, it will say Medicaid only there. Next, please. It shows any third party, so this would be your commercial insurance, and it doesn't show everybody, doesn't show your marketplace plans all the time, although I have seen CareSource Marketplace on there, so I don't know. Thank you. This information is provided by that right there. So to update third-party liability information, so you get on there and you see, hey, this is their Anthem BCBS from 1980. Chances are that just needs updated. So all you need to do is just prove that they don't have that coverage anymore. There's this 6614 form. So if you search for that on the Medicaid website, you can pull up the 6614 form and you can fill it out and say this person does not have this insurance, and it'll make it go away from the source of truth. That's the important piece. You need to make it go away in the source of truth. Now, if the managed care plan identifies that this person's TPL is present and or not present, they are also sending that information to Medicaid, and they're supposed to be like cross-referencing somehow. Next, please. Medicare. Okay, so for Medicare, it shows whether they have Medicare coverage. And they all display here, which I thought was funny that they put that in there, because it didn't at first. At first they decided they weren't going to put the plan name in, and it's like, but what plan? But what plan? There's so many. So now, basically, for all of us, what we care about is Plan B and Plan C. So if they have a Plan C present, they have Medicare Advantage, and that is who you're billing your things to. And oh, by the way, just ignore the term Medicare. It's essentially commercial insurance as far as we're concerned. You have to bill all providers there. I don't care if it's the CDCA that cannot credential. Don't have them see those members. It's kind of the name of the game there. So if they have a Plan C, it's Medicare Advantage, and that's a whole different set of rules. And then you got Medicare Plan B, original Medicare. If Medicare C is not present, that means that they have original Medicare, and that is the payer. And that one is, we have our TPL bypass list, so you don't have to bill the providers who are not eligible to enroll in Medicare. And they did expand that list, so now we have more people who can enroll, and if they can, they should. Because otherwise, you have to bill Medicare. Medicare is going to reject your claim. You won't even get a denial to be able to pass that on to Medicaid. So it gets really, really complicated with these dual individuals. Service limitation. So I don't know if anybody's tried this, but you can search for a certain procedure code. So like, let's say I am trying to see if they, I don't know what stay or how many days they have for H2034. They're residential. If you search for their eligibility include H2034, it will give you the service limitations and what has been used so far. So I find that interesting. Okay, so my favorite, and like I said, I'm gonna do my very best to explain this clearly, cohesively, and really ensure that you understand the benefit. So most of the time, you can go to the next slide. Most of the time, you're not gonna be going as in-depth with this as I'm gonna show you, so you don't necessarily need to read the files. It's helpful if you know how to read the files. But sometimes your EHR may have this functionality built into it if you're able to query a specific patient. I know I've seen that in certain systems. I know CareLogic, if you have the Inovalon integration, you can find eligibility, and all it's doing is it's submitting a 270 and then receiving a 271. So the 270 is the request, and then the 271 is the response. So it's a paired transaction. You're saying, hey, give me this data, and they have to give you the data. So it is a requirement that payers accept this transaction. And it includes other things as well. So it can include other coverage, dependent coverage level. You can do this for any payer. So, if I want to go out there and see, how far somebody is into their deductible phase, you can get that information from the 271. But you just have to know how to communicate with that payer. And there are different rules. Next slide, please. Okay, so who can submit and receive a 270, 271? So you have to be a trading partner. Well, what is a trading partner, you dare say? So a trading partner is anybody. A trading partner is somebody who has gotten authorization to send and receive files with this entity. And in this case, our entity is Medicaid. So you work with a lovely team of individuals. Joe Steinert over there, shout out. So really, really good team, but basically you can go through a process to be able to do this transaction for yourself, to send your patients information and receive the response of what coverage they have in batch. So I can take, it's up to 5,000 per ST to SE, and I'll explain that. So it's 5,000 requests at any given time. And we do this transaction for like 50 agencies, and I only have to split my files for like 2 of the agencies. So, most people are under 5,000, so it's pretty standard. It's gonna be your clearinghouse. So if you use like eTactics, you can do this through eTactics. If your EHR is integrated with a clearinghouse and supports this functionality, it might be available directly within your EHR. But it can be a provider or an agency. This is just one of those things. I don't know why you did it in the first place, because it's kind of out of left field, but BHBS is a trading partner, and we send and receive files. And we're authorized for all of the transactions. So we've been doing the 270, 271 process for many moons. And it's been incredibly helpful, right? Because we're able to query up to 5,000 patients and get responses for all of that at one time, rather than somebody having to individually 5 minutes per phone call, or 2 minutes per P&M query if it doesn't kick you out. Started doing that to me lately. And pro tip, free, right? It's free. So I can be a trading partner, and I can do these 5,000 transactions back and forth all day, and it's free. So you don't have to pay clearinghouse fees. You do have the ability to do it yourself. And I'm gonna talk about that now. Okay, so the search criteria. This is one thing, and I know you probably have received my emails if you're part of our 270, 271 process, but this has been one thing that they changed with OMES that's been really impactful, is that the search criteria has to be exact. So if you can search, it's a minimum of 2 pieces of information. So you can do name, go ahead and combine those, because that's one. So you can do name, date of birth. Name, social, name, MMIS, date of birth, MMIS, any of those combinations. And sometimes if you do more than that, it helps prompt better results as well. So I can do name, social, and MMIS. So then if I have a member who has maybe multiple Medicaid numbers, I can look at each of those individual Medicaid numbers and find the eligibility information related to each. So it's a little bit more flexible in the search criteria. It's just, it has to be exact. So the name, if they say junior on the PNM, you need to put the junior. If it doesn't say junior on the PNM, don't put that junior. Don't put that junior. It can't have any leading or trailing spaces in the name. So like maybe somebody got a little clumsy and they added a space at the end of the name in the EHR. Well, that just makes the whole file freak out and not return. So there's like a little bit of, you got to work with it. So you might have technical members of your team get involved, but it's flexible. You cannot use fake data. So if your system requires like a social security number and you're just entering 999, it will reject. It'll say, that's not that person's social. Well, I know that, but I needed to put a thing. So anyway, it's that kind of thing. It has to be exact. Do not send bad data. Next, please. You can do the same thing here as you can do in the PNM. So if you do want to search by a specific procedure code, you can do that within the 271. So that's nice. Okay, so I want to break down the file and explain this. This is the part I'm nervous about. Okay, next please. Okay, yeah, I know. So EDI basics, right? What is EDI other than scary and ugly and I can't read it? It is just like letters. It's electronic letters. So within the letters, you have an envelope. So you have a letter inside that envelope. So your envelope is your ISA to GS segment. So this is just saying, who's it to, who's it from, what am I doing with it? That's just the outside of the letter. Then you have your letter, okay? So the length of the letter, and there can be multiple. So you can have multiple ST to SE inside of your envelope. If you just want to shove a bunch of letters in there, you can do that. But the top of your letter is your ST, the bottom of your letter is your SE, and then you move into the contents of the letter. What is in your letter? Well, you have paragraphs that start with your HL, and inside of each HL, there's information about that entity, okay? So like between the HLs, if you want to find where one member starts and then the next member starts, look for HL. That's all that is. Okay, next. So then you get into the really funky stuff, and I'm not going to get too deep into this, but basically there's these little identifiers because it's a secret code. You got to know the secret code, and that's the whole point. It's supposed to be HIPAA compliant. It's supposed to be secret. It's supposed to be difficult to read so that if a bad actor obtains it, they're not getting sensitive information. So they have all these little codes. So like TRN1. You can send your ID that's in your system. So like CareLogic, you have your client ID. So we always send the client ID because when they respond, they're going to respond with whatever you sent in that TRN1 so that I can match it back up. That's your identifier. NM1, any of your NM1, that's naming an entity. It could be the payer, who I'm sending it to. It could be the agency that I'm sending it on behalf of. And it could be the member that I'm sending it for. There's all of these date segments, so everything is very date dependent. So anything that starts with that DMG D8 is your date of birth, and then you've got a social, and then you've got a coverage date range. And then in the 271, this is where you start to find the information about their coverage. And I know I'm running out of time, so I'm going to kind of skip a little. What you need to know here, EB1 equals active. So it's saying this is active coverage, EB1. There are multiple EB lines, okay? So for one member, I've seen like 30 EB lines, okay? They can have a lot. And it's just each benefit is outlined in an EB segment. But EB1 130. 30 is health benefit plan coverage. So like when you go into some of these other portals and it's like, oh, you're gonna search by a benefit type, some people think you would put in mental health or substance abuse as the coverage type. We're health benefit plan coverage. That's what it is. So 30 is what you're searching for. And in the 270, you request 30. The 271 will give you back those coverage, but sometimes more. So identifying your 30 is what you're looking for. If it says EB6 instead of EB1, it means that they're inactive. Next, please. Okay, so this is what it looks like. And this is where I'm saying it's ugly, it's scary, but I love it. So just here, this is your 270. This is the ask. What am I asking for? I'm asking for TRN1. This is my client ID that I'm requesting. This is my submitter, my TIN. So this is BHBS. This is the subscriber's information, beautifully DPH'd by EMS Informatics tool. You've got your ref SY, so that's their social, that's their date of birth, and then this is the range I'm asking about, and I'm asking about health plan coverage. So then the response, Ohio Department of Medicaid responds, and you've got that whole top part of your letter. Just ignore all that crap at the top. Then you go down here. So you've got your TRN 2, and I'm looking for the one that I sent it for, 102236, 102236. So this is the information. There's the top, there's my HL. So this is where it starts. And then when I get to my next HL, different patient. But here, notice that it will respond with information. And this is real, by the way. So it responded, I submitted their first name, last name, and their member ID, and their social. So all three of those data points. And it responded with the same ones. But it also gives me their address. And then it gives me their date of birth. I did not, well, yeah, I did submit their date of birth. But either way, sometimes it will return with more information than what you submitted. And then I get into their EB lines. Like I said, there can be several of these. So you are looking at multiple. This member in particular has Ohio Rise. And the dates I requested, the eligibility dates. This 346 is the date that that plan began. So for Ohio Rise, we know that that can begin any time of the month. Well, this member began on 6/14/2025. And I asked, so I was querying the month of August. Now, if I go down to the next EB line, and I'm looking for EB 130, they have Buckeye as their managed care plan. And then there's this acronym. Can we go to next? So this, the aid category and where it lives, okay? Well, it's in that EB line, specifically EB 05. So 05 is how many asterisks are in between the data points. And this code is what is identifying the type of Medicaid coverage. This is how Medicaid is classifying folks in their system. They use it for all kinds of things, beautiful charts and things, but you can use it too. So there's the aid code between the numbers, and then at the end of these EB lines, it'll have an acronym. That acronym is the same thing in the explanation and benefits section of the P&M. So you've got Medicaid, mental health, alcohol and drug, and MRDD, right? And those will all return here. And if they have RX coverage, things like that, is what'll be there. Next, please. 47, 2 over, okay. So yeah, basically, that's what you're looking for. This aid code, what is next? Oh, the actual thing. Okay, so these aid codes are out there, and if you come talk to me tomorrow in my session, I'm gonna, and it gets a little technical, but it's not that hard, but I'm gonna show you how you can access this information, get it into Excel so that you can actually use it for reporting and comparative purposes, and you can do something with this information and understand who is this population that really needs this assistance. Now, for the FQHCs, there is this additional number for the wraparound. I don't know how many of these folks we have in the room. This wasn't working, but it is now. And we are able to parse it out. You're looking for this SV and then a number. And this number returns in the 270, 271 process. It is in the PNM as well. Okay, so yeah, I put things in here. So if you don't attend my session and you like Excel, you can play with these if you want. If you do come, I'm going to talk about it. There's also information about how to become a trading partner. And the last thing I'm going to show you is putting this data to use. So this is from our 270, 271 process, and I was able to accurately classify my 3 main categories. Out of the 37,000 members that we queried in the month of September, I have 30% expansion, I have 30% ABD or dual or buy-in, I have 36% CFC, and then there's this other, right? This is your QMB, SLMB. So it's a lot, guys. That expansion population, particularly for mental health and substance use agencies, is higher than the numbers you're seeing elsewhere. 30%. Of that 30%, this is what makes that up. So it's generally expansion, MAGI, expansion non-disabled adult, less than or equal to 66% of the federal poverty line. And I have a couple of slides in here that kind of go through what makes up those categories, but I know I took more time than I was supposed to. So you can look at those in the information that's been provided. And guess what? It's lunch. Isn't that great? Thank you for